Yes, sir. Start. 3, 2, 1.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today we have a presentation on chyluria. And this would be presented by our resident, Dr. Rajiv Sharma, and would be moderated by our faculty, Dr. MANOJ. So I would request Dr. Rajiv to kindly share his presentation. And in the meantime, Mr. Nimesh Ji, if the experts, Dr. Apul or Dr. Dalila joins, please let me know, right? Okay. Rajiv, go ahead, please.
Yes. Good morning, sir. Good morning, respected teachers and my dear colleagues. Today's topic for seminar is on chyluria. Chyluria is a urological manifestation of lymphatic system abnormality, which is characterized by presence of chyle in urine. It is a state of chronic lympho-urinary reflux via the fistulous communication secondary to lymphatic stasis caused by obstruction of the lymphatic flow. The genitourinary lymphatics are damaged, resulting in the lymph passage into the urine and massive fat loss and protein loss. It is prevalent among the African and Indian subcontinent, mostly due to filariasis. It is common in the age group of second and third decade, and left-sided kidney is most commonly involved. Etiology can be because of parasitic infection and non-parasitic. Various parasites, most of the 95% of the cases because of Wucheria menpropty. Other causes can be Taenia, Echinococcus. Non-parasitic can be because of surgery, infection, malignancy, and lymphatic malformations. Ackerman suggested that the blockage of the major lymphatics or the thoracic duct results in the retrograde flow of lymph from the gut into the lumen of the urinary tract. Mention suggested that the rupture of the lymph pharynx anywhere in the urinary tract leads to escape of the lymph in the urine. The recent theory says that the inflammatory reaction due to parasitic or bacterial infection can cause obliterative lymphangitis, which results in valvular incompetence, retrograde flow, and varicosities, which ultimately rupture and leads to the fistula formation. Anatomy of renal lymphatics, it can be categorized into it is trilaminar, and the first lamina lies within the renal parenchyma, second in the subcapsular level, and third in the perinephric space. And the lymph flows from the lymph capillaries to the lymphatic vessels and lymphatic duct, which finally join the subclavian vein. This figure shows the lymph flowing from the lumbar trunk to the cisterna chyla and to the thoracic duct, and ultimately at the subclavian junction. The pathophysiology of the chyluria is given by the obstructive theory and regurgitative theory. In obstructive theory, this states that the parasitic infection leads to obliterative lymphangitis and lymphatic hypertension, which leads to formation of varicosities and collaterals, which can rupture, which can lead to backflow into the urinary tract. In regurgitative theory, chyle is regurgitated from the cisterna chyla or large intestinal trunks into the renal lymphatics, which can cause lymphatics to rupture into the renal pelvis. This figure shows the lymphatic outflow dysfunction and lymphatic inflow dysfunction. Chyluria is manifested as milky urine, and patient complains of frequent urination, burning, micturition of blood in the urine, as well as weight loss due to protein loss in the urine. Properties, the chylous urine on appearance is milky white. When allowed to settle down, it forms three layers. The topmost layer is that of the fat, and middle layer is that of the protein, and the bottom layer consists of cell debris. The 24-hour proteinuria is of the range of nephrotic range proteinuria. The recurrent chyluria the episodes can last up to the weeks, or days or weeks. The chyluria is graded as mild, moderate, and severe. The mild chyluria involves one calyx. Moderate chyluria is usually intermittent and involves two or more calyces. The severe chyluria it shows continuous milky urine, and most of the calyces are involved. Various investigations involve urine examination, blood examination, cystourethroskopy, RGP, lymphangiography, lymphocytography, and MRI, USG, etc. Chylous urine is best studied immediately after it has been voided. The fatty diet a day before should be taken by the patient. On gross inspection, the urine is milky. When kept to stand, it shows 3 layers. This figure shows the ether test done for chylous urine. In this, the test tube C shows the separation of the fat globules by addition of the chloroform into the urine. Other urinary investigations for chyluria like Sudan 3 staining, Sudan 3 injection test, and electrophoresis are done. In this figure, the microscopy of the chylous urine shows the various lymphocytes and isomorphic erythrocytes on modified right staining. Blood examination shows eosinophilias, antibodies against the filarial antigen, and hypoalbuminuria. Renal biopsy is rarely done now, basically for research purpose. In this, on cystoscopy, there is a reflux of milky urine from the ureteric orifice. RGP helps to demonstrate the pyelolymphatic backflow. It is done by ureteric catheterization into the pelvis, and the spot films are taken, and the patient is made to stay in the head-down position. In this retrograde pyelogram, there are mild, moderate, and severe pyelolymphatic fistula. Lymphangiography, in this, it was previously the investigation of choice, but is rarely done now. Lymphangiocintigraphy is a useful, non-invasive, and safe procedure. It helps to. It is indicated when the RGP fails to demonstrate the reflux. In this, there is a chylous clot present in the urinary bladder on ultrasound. Management of chyluria should be considered if the as due to filarial causes or until proven otherwise. Medical management involves basically bed rest, dietary modification, use of anti-filarial drugs like diethylcarbamazine, ivermectin, and albendazole. Spontaneous remission can be expected in about 6 months. Sclerotherapy is indicated when there is failed conservative management. The various agents are silver nitrate, povidone iodine, dextrose 50%, hypertonic saline 76%, and this can be used in combination therapy. The sclerosing agents are the procedure is usually done under local anesthesia. If fatty meal on previous night and cystoscopic visualization of the affected site is done. During installation, the patient is he should be in the head down position, and over distension of the renal pelvis should be avoided. The other side is tested after 6 weeks only. On installation of the sclerosing agent reaches the lymphatics through pyelolymphatic fistula, where chemical lymphangitis occurs, and immediate relief is achieved by edema, and long-term relief is achieved by healing by fibrosis. The dose schedule is the sclerosing agent is instilled 8 hourly for 3 days, or 12 hourly for 2 days, or weekly for 6 to 8 weeks. Povidone iodine, the installation is done by 0.2%, and all the patients who were treated by this method, they were relieved of chyluria at the end of 6 months follow-up. Silver nitrate is the most commonly used sclerosing agent, and it's used in the concentration range of 0.1 to 1%. The combination therapy is used when a stronger fibrotic response is expected, and it can be used with the help of combined povidone iodine with 50% dextrose solution. Various complications can be hematuria, fever, pain abdomen, acute tubular necrosis. Surgery is indicated in case of refractory chyluria, or when there is weight loss and hypoalbuminemia, when there is recurrent clot formation, hematochyluriae, or when there is an altered immune status. Various surgical procedures are surgical lymphatic disconnection, renal autotransplantation, nephrectomy, microsurgical procedures like lymphovenous anastomosis, lymph nodovenous anastomosis. Lymphovenous disconnection. The kidney is freed all around, and dilated lymphatics around the renal vein and artery are ligated for 1 centimeter circumferentially. It can extend even till the level of bladder. Surgical lymphatic disconnection. It consists of nephrolympholisis, ureterolympholisis, hilar vessel stripping, Girotta fasciectomy, and nephropexy. Lymphovenous anastomosis. This is the most physiological method for surgical correction of chyluria. This procedure increases the drainage of lymph into the venous system, which rapidly decreases the intralymphatic pressure. The procedure is technically cumbersome as the lymphatic channels are thin and brittle. It is of two types: retroperitoneal lymphovenous anastomosis and transinguinal spermatic lymphovenous anastomosis. This figure shows transinguinal spermatic lymphovenous anastomosis. Microsurgical procedures include lymphangovenous anastomosis and lymph-nodovenous anastomosis. The advantage is that the procedure is relatively superficial and simpler. It obviates the use of lymphangiography and cystoscopy since there is no relation between the operation and the site of lymphorenal fistula. Disadvantage is that it is technically demanding and it may take about 6 months for the relief to occur. Indications of microsurgical procedures are these are indicated when there is persistent or recurrent chyluria. In case of older and weaker patients who could not tolerate the ligation and division of lymphatics. In men, the lymphangovenous anastomosis is done on the inguinal region. If the diameter of the lymphatics is less than 0.1 mm, then a bundle of lymph vessel is cut and inserted into the vein of the corresponding caliber with few anchoring stitches. Renal outer transplantation is done only when the lymphovenous disconnection has failed. The omental wrapping of the kidney is done bilateral after bilateral nephrolysis. The omental wrapping reduces the lymphocyte by absorbing lymph and obviates the use of drain. It decreases the recurrence and ease of reoperation if recurrence occurs. Nephrectomy is done when the kidneys are non-functional following lymphovenous disconnection. Inguinal lymph node and saphenous vein anastomosis is done. It is made according to the principle of lymphovenous shunt. A conical tissue of lymph node close to the greater saphenous vein in the inguinal region is removed, and the remaining tunnel-shaped node is anastomosed to the vein to drain the lymph into the venous system. This operation avoids the damage to the afferent and efferent lymphatic vessels and affords a large anastomotic stoma for free passage of lymph into the vein. Role of diet in chyluria. A low-fat and high-protein diet as a conservative method of treatment of chyluria is mostly successful. Dietary recommendations include the limiting of fat intake to less than 25 grams per day. It should include medium-chain triglycerides and use of skimmed milk and avoid deep-fried foods. Basic approach to chyluria. In case of suspected chyluria, diagnostic tests are done whether to rule out parasitic infection or other causes by either analysis of urine or radiological method and cystoscopy. Then grading is done and treatment is done either by conservative method or by dietary modification or surgical and microsurgical procedures. The causes of recurrence of chyluria can be categorized as early recurrence, which is due to inadequate sclerotherapy, incomplete stripping, and release of chyle from the contralateral unit, fistula in the lower part of the ureter and bladder. Late recurrence is due to recanalization of the lymphatic fistula to the operated kidney. Treatment option for the recurrent chyluria can be intrapelvic reinstillation of silver nitrate solution, retroperitoneal lymphovenous anastomosis, transinguinal spermatic lymphaticovenous anastomosis, renal outer transplantation. This algorithm shows management of recurrent chyluria by resclerotherapy, which is done, which if fails, then it's followed by chylolymphatic disconnection, which can be open or laparoscopic. If it also fails, then microvascular procedures are done like lymphovenous and lymphonodovenous anastomosis. And if they also fail, then outer renal transplantation and rarely nephrectomy is done. Thank you.
Thank you. I'm just coming, yes.
Hello. Yeah. So anybody has any query? Residents, faculty, want to say anything? Anybody? Nimesh, has Dr. Apul joined? No?
No, sir. No, sir.
Okay, okay. I think he was saying probably would be difficult for him to join. But let me tell you that if you just go into the literature, because chyluria is not very common in Western world. So whatever literature is there is majority from our countries like India and China. So there are few articles from KGMC where Dr. Dalela's articles are often cited in chyluria. Then Dr. Apul Goyal also had a kind of a comparative study between the various sclerosing agents. And then there was a article from SGPGI, an experience of SGPGI for chyluria. I think, again, being in this subcontinent, the topic is important. A lot of people, there are around 120 million people suffering from filariasis, right, around the world. And the majority belong to the Asian countries like India, China, and the neighboring countries, and some countries of Africa. So do you have any question? Then otherwise, I will briefly summarize the whole thing, and then we'll take up the MCQs. So if you don't have any question, we will, chyluria, you all know, as he has already explained you, is presence of chyle in urine, right? And it is due to communication, a fistulous communication between the lymphatic system and the urinary tract. So this could be due to basically two reasons. One is a parasitic infection, is a non-parasitic. Parasitic, as he said, Wuchereria bancrofti is 95% cases, and the rest could be Taenia echinococcus, Taenia nana, and trichiniasis, right? And non-parasitic causes, which are more common in the Western world, this will include trauma. There's a blunt trauma of the abdomen or the penetrating injury, then surgery, some retroperitoneal surgery, particularly, and partial nephrectomies, often many times have been found to have post-operatively developing chyluria. Then there are causes like other infective causes. It could be radiation, it could be malignancy. There are some congenital causes also. There could be a congenital communication between bladder and the lymphatic system, and some infants and children can also present with chyluria, right? So these are non-parasitic causes. When we talk about the clinical symptoms, the most common, the patient will present with the milky urine. But milky urine should be have a differential diagnosis with three important conditions, right? Phosphaturia, pyuria. Yes, I think these are the three important conditions. So how would you differentiate between the three? So on standing, yeah, on standing, yes. Pardon? Acetic acid, 1 to 2% acetic acid, yes. So, and chyluria? Ether, right. And on standing, it forms three layers. Yeah. So chyle is basically composed of albumin, fat, and fibrin, right? So fibrin deposits, there's a middle layer of fat and the albumin, right? So patient will present with passage of milky urine. Secondly, the other symptoms could be patient, as he said, dysuria, frequency. Sometimes they may be hematuria, right? So hematochyluria is one of the very important findings in particularly moderate to severe cases. And then there could be clot colic, the chylous clots formation in the bladder and the ureter. It may produce colic also. Some patients may present with kind of a pain, flank pain, fever. Sometimes they may present with loss of weight, cachexia, and all that because of hyperproteinemia. And so this would depend upon the severity. As I said, there are three grades: mild, moderate, severe. So mild is usually when they present with intermittent chyluria, involves usually only one calyx, and there is no other symptom, usually, only chyluria. And the second is moderate, where there is 2 or more calyces involved. It is again intermittent chyluria, but there may be associated symptom like clot colic or chylous clots formation, etc. And the third is the severe form, where almost all calyces are involved, and it's a continuous chyluria, and there is associated hyperproteinemia and weight loss and all that. Right. So whenever this patient presents, usually the male-female ratio, because in our country, filariasis is the commonest cause, 9:1 ratio of male is to female. It has been found. So we need to take a proper history of the patient, the endemicity, where he is coming from, whether this is endemic for filariasis, whether he has visited an endemic country or place. So that is important. And then other symptoms associated that has to be taken care of. And if it is we're thinking in terms of non-parasitic, then we need to take a proper history of trauma, surgery, infection, radiation, other causes, right? So once you have taken a proper history, the physical examination, again, important. And the investigations, yes, presence of chyle in urine is the most sensitive and significant kind of a test. And then the presence of triglycerides in the urine. Triglycerides are present in almost in 100% cases. So presence of chyle and urine triglycerides. And then sometimes you have this Sudan 3, which stains the fat in urine red. So Sudan 3 staining is important. Sometimes you can give Sudan 3 combined with butter. And then if you give this, the patient usually will present with pinkish urine, right? So that is again another test to find out the presence of chyle in urine. And then you have, if you think that this is filarial, then you need to do a filarial antigen test. And eosinophils can be raised in the blood. There may be hyperproteinemia in the blood. And then you need to do some imaging study to do a lateralization and find out the site of communication. And that is done by either CT urogram or intravenous urogram or retrograde pyelogram study, or sometimes even MRI. Pregnancy is one of the reasons why there may be increase in chyluria. So in that case, you may do an MRI. And then the most specific test is a lymphangiography. Though it's a kind of an invasive test and it's quite cumbersome. So nobody probably does lymphangiography nowadays. So lymphoscintigraphy is another test which can be done. And to find out. And then you need to do a cystoscopy to lateralize which kidney is having chyluria. And then by doing a RGP study, a dye study, you can actually find out the communication also. Where is the fistulous communication? So this helps in investigating the case. And then the management, as you said, the 4 different managements. One is the conservative therapy, particularly in mild cases. It has been seen that 50% cases may resolve by themselves. And the conservative therapy will include diet therapy, fluid. So you increase the amount of fluids in the diet. You give high protein and low fat diet. And when you think of fat, then you have to give medium chain triglycerides, right? And the coconut oil is the best oil as a medium chain triglyceride, which can be given to these patients, and avoid other oil and fat and ghee and all those things, right? And then bed rest is important sometimes. Sometimes they use abdominal binders, which increases the intra-abdominal pressure and prevents the regurgitation of the lymph, all right? So all these are important as a conservative therapy. Then pharmacological therapy. In endemic countries, we may not do a filarial antigen test, but ideally you should do. You can start with diethyl carbamazine citrate, 100 milligram thrice daily for 3 weeks. Sometimes it has to be repeated after 8 weeks. You have to give albendazole and ivermectin is usually given 6 to 12 milligram once a day by stat dose. And albendazole usually 400 milligram, which is given for 10 to 14 days. Right? And sometimes they give benzathine penicillin also for infective causes, and sometimes doxycycline is also used. So these are the pharmacotherapy agents, sometimes even for non-parasitic causes, and other causes they have used somatostatin analogs. Right? Somatostatin analogs have been used to treat chyluria. Even ACE inhibitors, enalapril has been used for treating chyluria. Right? And then we can come to the sclerosing agents. Sclerotherapy, mainly the three important is silver nitrate, povidone iodine, and 50% dextrose, and hypertonic saline, right? So 50 and betadine is 0.2%. Usually you can make a mixture by using 5% povidone iodine mixed with 40 ml of distilled water. So 10 ml of povidone iodine, 5% with 40 ml of distilled water, you make 0.2% of povidone iodine. And then silver nitrate, 0.1%, use silver nitrate. And usually the regime is either you give thrice daily for 3 days or weekly for 6 to 12 weeks, 6 weeks, 8 weeks. And there are various regimes they have worked. So I think the best probably, which causes least side effects, would be povidone iodine. Silver nitrate may cause some problems sometimes, and it is difficult to sterilize them because they have to be autoclaved and the water vaporizes. So there may be a problem with silver nitrate. So this paper of Apul Goel, which compares the three sclerosing agents, they concluded that povidone iodine is probably the safest and the simplest form of sclerosing agent. Sometimes even doing an IVU or putting a dye can cause sclerosis. So that also helps in sometimes blocking. When you do a study and you find that the chyluria has stopped. So this is also possible. And the next is the surgery. The lymphatic disc connection from kidney. Usually it is seen that you did not disconnect the whole thing. The major part is the medial side, the renal pelvis and the vessels, the hilar vessels, and the upper ureter, which needs to be disconnected and made bare, right? And then you do a nephropexy later. And sometimes you may do lymphovenous anastomosis. The saphenous vein may be connected to the inguinal lymph node. And then autotransplantation. And lastly, if the kidney is non-functioning, then you do a nephrectomy, right? So again, recurrent chyluria is another important chapter. So if the patient doesn't respond to conservative or pharmacotherapy, we need to give sclerosing agents or then surgery, right? So I think this was in brief the summary of chyluria. So if anybody, Dr. Nachiket, would you like to say anything?
The only thing is that they shouldn't forget about hematocrit.
Yeah.
Because it causes a lot of anemia, and these patients are really sick, especially if you go to Eastern UP and Kerala. They come with hemoglobin of 4 or 5 because it also causes a lot of hematuria. So hematocrit.
Yeah. So as we discussed, in moderate to severe cases, hematochyluria is quite often present. They may have present with clot colic also. So and then we can also so that is another point, very important point. The patient may present anemia because of the loss of blood, besides hypoproteinemia and cachexia and weight loss. So again, very important, right?
So medical, that emblem in which there is a stick and the snake is going around that. So basically, that is the depiction of Dracunculus. Pele, they used to take out Dracunculus by just tying a stick around it. So वो वाला जो emblem है medical का.
Yeah. Please, that's a very interesting thing, Dr. Nachiket. I think whenever you want something interesting, we can ask Dr. Nachiket to, yes. Please, Nachiket, go ahead.
We know this. This is because where I did my MCH
there were a lot of cases of kylluria. And every OPD, there used to be 1 or 2 cases of kylluria. And even in BHO, we had a very large series. One of my contemporaries, PR Nandi, he published a large series which came out inside Gold Journal. So about that medical emblem in which there is a stick, and we think that it's a snake going around the stick. So basically, it's not a snake. It is basically the Dracunculus medinensis. And in villages, how they used to take out the Dracunculus medinensis was that they used to see the head of the Dracunculus. They used to widen the area around the head with some stick, and then the Dracunculus used to come around the stick. So if you just type it on Google, also this was told by my teacher, that it is a depiction of Dracunculus medinensis around the stick, because that is the way that they used to remove it from the skin.
Okay. So what is
ये गिनी वर्म जो होते हैं सर, गिनी वर्म जो है ना, that is the intermediate parasite for kylluria. हाँ, लेकिन this is basically Dracunculus. This can, because it's just not filariasis. जैसे अपने राजस्थान में it can be caused by Dracunculus, which was endemic at that time. So a depiction of that. Do you have Google over here, इसमें? If you have Google, then you can just type. What is the depiction of?
Very important, very interesting information, rather. We have seen the emblem so many times for the doctors, right? A serpent around a stick, right? This is not actually a serpent. This is a, I think, parasite, is it? Dracunculus medinensis. And yes, so just type Dracunculus, or you can type our emblem. Is it? What is the? Yeah. Okay. Right. That's great. Very interesting. I think you need to be a lot more observant and try to find out how the things have happened. And so this is a very interesting piece of information.
This is illustration of a guinea worm, and this is the stick.
Yeah.
So they say Dracunculus medinensis. This is how they used to take it out
in
the villages, because it forms a big ulcer.
Yeah, that's true.
So then they used to use that stick, and they used to tie the guinea worm. Slowly used to come around the stick.
Right.
So that was.
So you think that you actually know that the emblem is actually depicting this, is it?
Sir,
yeah.
That's one of the things. The other thing is some Greek mythology.
I think Greek mythology is also there, right? Okay. Thank you, Nachi. For anybody has any other information or any comment to make? Otherwise, we'll go with MCQs.
About the silver nitrate. Silver nitrate can cause CKD and AKD. Because if you dilute it with normal saline, then there was a paper from SEPJ in which they cause silver chloride precipitation in the whole of the kidney, and after that, silver nitrate has more complications on account of dilution.
Yeah. So yes. So usually you dilute with distilled water. You don't use it normal saline. Even betadine, povidone iodine is diluted with distilled water. Yes, but what the experience that we have in our center, we have used silver nitrate quite often. I think I remember around 4 or 5 cases doing with silver nitrate. Fortunately, we didn't have any complication in any of these patients. But yes, the study that Dr. Appel says, probably the more important is it is very difficult to autoclave them, and the water vaporizes, and so the sterility is again a concern. So that's why povidone iodine probably may be the simplest thing to do. Yes, go ahead with that. So we will go to MCQs. The first question is: involvement of 2 or more calyces on RGP corresponds to which severity of kylluria? Right, moderate. So we have already discussed it. The severe is all calyces, mild is 1 calyx, and I don't think there is a permanent variety. So these are 3 grades. Kylluria is treated with medium chain fatty acids, long chain fatty acids, triglycerides. So medium chain fatty acids, and the best example is the coconut oil. So you ask the patients to use coconut oil and avoid any other fatty food, right? Or ghee or any kind of other oil. So the basic thing here is the medium chain triglycerides, they bypass the intestinal lymphatics, and they go directly to the portal system. That is why this is more important. The medium chain triglycerides, they don't cause chyluria because they bypass the intestinal lymphatics. And we know triglycerides, the commonest thing to the test for chyluria. All are true about chylous urine, except chylous urine is more pronounced in evening. Nephrotic range proteinuria, lymphopenia separates into 3 layers when urine allowed to stand. So it's more in morning? After meals. So it's more important after meals. Usually that's why you take the urine examination after usually 2 to 4 hours after having a fatty meal. So that will, you will find the chyle in the urine and the test will become positive, right? I think the rest are common. Nephrotic range proteinuria may be possible in chyluria, right? And that's why you also do a 24 hours urinary protein in these patients to find out the level of proteinuria. That is again another test. And lymphopenia, yes, lymphocytes. There is on urine routine microscopy, you will find lymphocyturia, right? Besides the presence of chyle and triglycerides. Sclerotherapy in chyluria involves all except done if DC therapy and dietary modification fail. Healing by fibrosis leads to permanent relief. During installation, patient is placed in head down position. 76% urographin is most commonly used sclerosing. So,
it doesn't cause permanent relief.
So not necessarily, it may cause. So what is your answer? D. So it may cause permanent relief, not necessarily that 100% require the kind of surgery. So many patients, in fact, the patients that we have dealt with, almost all patients responded to sclerosing agents. Probably they were not that severe, which required, again, surgery. So again, during installation, usually the patient is placed on a head-down position, and 76% is most commonly. It's not the most common, though it may cause sclerosis. Right? Which diagnostic test is most specific for chyluria? Urine microscopy, Sudan-3 staining of urine, X-ray KOB, CT urogram.
Sudan-3 staining of urine.
Right. So Sudan-3 will stain fat as red, right? Yes. And that is the most specific test. Otherwise, you can get triglycerides in urine right. And then, as I said, Sudan-3 can be mixed with butter and given to a patient where the urine becomes pinkish the next day. Which surgical procedure is recommended for refractory cases of chyluria? Lymphangiography is not a surgical procedure. Nephrectomy, lymphatic venous anastomosis, and uretroplasty. Lymphatic venous anastomosis. So either lymphatic or even why not disconnection? If it is surgical procedure for refractory cases, okay. So once if the disconnection has also failed, then you need to do a lymphovenous anastomosis. And one of the common is the lymph node with saphenous vein, and an inguinal lymph node with saphenous vein. Right. Thank you. Thank you once again. Nimesh, any other person has joined us? No.
No, sir. No, sir.
I don't think so. It's a early new year, so I think, and then probably they have their classes also. Dr. Apul was busy somewhere, and Dr. Dalila's this period is also quite busy, 8 to 9. So he does usually yoga and all that. So he's not able to come. So though they were the most very kind of important experts in our country for filariasis, Dr. Apul has written a book also on filariasis. So if you get a chance, read that book and read the articles. Thank you once again, and have a good day.